So we are live, and it does look like Alicia's frozen. So
we can give her a minute because I could always kind of jump into our introduction and then come back.
yeah, that might be a good idea because she is frozen, and yeah, that might be a good idea until she comes back. Yes, please go ahead, Dr. McKean.
All right, so go ahead and get started here.
Yes, let's get started. Yes.
All right, great. Well, good morning, everyone, and thank you for joining us. We're excited to be here with the AIM at Melanoma Foundation and my colleagues from Sarah Cannon Research Institute to discuss melanoma this morning. So we're going to jump ahead. I know Alicia does have some introductions, but is having a few technical issues. So I will go ahead and get started, and then we'll circle back to Alicia when she's ready. All right, so this morning, Living with Melanoma, and this is our virtual patient symposium. I just want to give a little introduction to Sarah Cannon Research Institute. Some of you may be familiar with what this is, maybe patients of ours, or others of you that joined through AIM at Melanoma and maybe not heard of Sarah Cannon before. So why do we exist as Sarah Cannon Research Institute? Well, we know cancer, as hard as we're working, is not going away. And that 1 in 2 in every males and 1 in 3 of every female will be diagnosed with cancer. And 85% of people facing cancer seek care in their own communities. So while all of us were trained at fantastic academic institutions and love our colleagues there, most patients are choosing to get their care at the clinic that's closest to them so they can sleep in their own bed at night and be able to have that support locally. But the challenge is that new therapies only become available to patients through clinical research, and only 5% of the US population participates in clinical research. Well, why is that? And that's because historically, a lot of clinical trials were only available at these academic centers in major urban areas. And so the idea behind Sarah Cannon is that participation in a clinical trial should be the first option in fighting cancer, not the last. And so since the majority of patients do seek care in their own communities, that world-class care should be accessible to everyone with a diagnosis of cancer. And so one of the concerns that we'd heard was that patients would fear giving up access to these novel therapies in clinical trials because they were getting cancer care in their community. And physicians in the community wanted access and wanted to participate in clinical research. And so at Sarah Cannon, our mission is that people who face cancer are at the heart of every decision we make. And SCRI is transforming cancer care around the world by collaborating with scientific partners, physicians, and patients to advance cutting-edge research in the community. And so the whole premise is trying to take expertise, clinical trials, and bring it closer to home. And so we've done this by expanding physician access to research, being able to offer more clinical trial options to patients at their clinics closest to home, and then really trying to transform drug development and being able to enroll a diversity of patients onto clinical trials, and also have that experience of, if this drug gets FDA approved, what does that mean and what does that look like to give that at every clinic across the country, as opposed to just individual centers. And so our theme is today's clinical trials are tomorrow's therapies. And we really believe in that, right? Any advances that we've made, especially in melanoma, started off as a clinical trial. That was a way to be able to get earlier access for patients. And that's really, those are the therapies that have really made the breakthroughs that we've had in melanoma and hope to continue making. And so you may ask, well, where does the name Sarah Cannon come from? Well, I wish I could ask for a show of hands here, but not sure how many of you are familiar with Minnie Pearl. She was famous for the phrase, howdy. I'm just so proud to be here. So Minnie Pearl, her real name was Sarah Cannon. And so she was a television radio personality a few decades ago that was known as Minnie Pearl at the Grand Ole Opry. And so Sarah Cannon had been diagnosed with breast cancer, lived here in Nashville. And so she received treatment at our center years ago, and she wanted to do more. And she wanted to, kind of came to the table saying, what can I do to help advance cancer treatments, cancer research? And so she offered to give her name. It was initially actually the Minnie Pearl Network. And then after she passed, her family had said, well, it wasn't Minnie Pearl that had cancer, it was Sarah Cannon. And we really want her name to be known. And so she that was over 30 years ago that it initially established. And so the idea was to use her name to promote cancer research and patient education with the vision of offering patients convenient access to early detection, clinical trials, and a team approach to cancer care. So I think just a super interesting tidbit. The other story I always like to tie in is that her radiation oncologist had said, my daughter's a pretty good singer. And so Minnie Pearl or Sarah Cannon had connected. And so Dr. Grant's daughter, Amy Grant, actually got her start through treating Sarah Cannon. And so what does Sarah Cannon look like? So we actually have 250 locations in 24 states. So that means we have 1,300 physicians across that network that we consider research physicians. We're able to offer clinical trials to patients. We have over 1,000 clinical trials actively enrolling, and over 4,500 patients are able to participate in these clinical trials every year in the communities closest to home. And so today we've brought together speakers from across the country, across our network that are really passionate about melanoma and melanoma care to deliver our talks today and participate in the panel discussion later. So I'll be kicking us off. I'm based in Nashville. So my name is Meredith McKean. I'm a medical oncologist and the director of the melanoma and skin cancer research at Sarah Cannon. You can see up top, I'll next move to Dr. Amatruda. He'll be presenting on personalizing your melanoma treatment. Dr. Amatruda is also a medical oncologist at Minnesota Oncology, and I look forward to hearing his talk. We'll then move to Dr. Waite, based in Denver, Colorado. He'll be discussing immune and cellular therapy 101. Dr. Waite is a medical oncologist and the medical director for the Melanoma and Skin Cancer Institute and Sarah Cannon Research Institute at Health One, located there in Denver. And then we'll finish up with Dr. Yorio. So he's going to present on what should I know about clinical trials. Dr. Yorio is a medical oncologist and is the Central Texas Site Research Leader for Sarah Cannon Research Institute at Texas Oncology. He's also the Chief of Hematology Oncology at Ascension Seton Medical Center, Austin. So I think just a fun opportunity to have a number of experts from across the country really being able to give great talks today, and hopefully an engaging panel that we're looking forward to answering your questions. And so before I dive in, I'm just going to check and see if Alicia was able to log back in, if she wanted to give any words before I started with melanoma prevention.
Yes, hi, thank you. Sorry, one of those internet Zoom issues, but I'm Alicia, the Vice President of AIM at Melanoma, and we're thrilled to welcome all these great physicians here today. I want to let all of you know that the Q&A at the end will cover all the speakers. So we won't have Q&A after each speaker, we'll have it at the end. If you have questions, and we hope you do, those who are on Zoom, your viewer questions can go in the Q&A tab. If you're here joining us Facebook or YouTube through one of those, they should be placed in the comments section, and we'll transfer those over to Zoom. So again, all the questions are going to be at the end, and all of the physicians will respond. You could direct to a single physician or more than one. And Zoom goes through Q&A, Facebook and YouTube, please in the comments section. And I'll tell you a little bit more about AIM near the end, but I'll let Dr. McKean take it away. Thank you.
All right, sounds great. I'll get my presentation back up here. Great. Well, I hope that is full screen. All right, so I've been tasked with, we thought it would be just helpful to go over melanoma prevention and kind of where we are with, I think I gave a talk similar to this for an AIM at Melanoma Patient Symposium like 5 years ago. And there's been such an evolution in, UV clothing and other, just other options. And so just hoping to go through that today. So we're going to just go over some, I termed it anatomy, but just some of the basics of melanoma, UV radiation, into sun protective measures such as sunscreens, UV clothing, tanning. I don't probably have to tell this crowd the dangers of tanning, and then early detection, and just briefly on genetics. So certainly this is a cross section, just reviewing the anatomy of the skin as we talk about UV radiation. And so I try to draw this out for patients in clinic when we talk about melanoma. So the upper layer is the epidermis. That's where the, tell folks that's where kind of the skin cells can slough off deeper into the dermis. That's where you have your blood vessels, your lymph nodes, your nerves. And so the melanocytes kind of sit right in between that layer, as you can see in the, I'm not sure if you can see my cursor there, but right in the middle there, in between the basal cells and the squamous cells are above that. And so that outermost layer, the epidermis, is really protecting us from the environment, trying to be a moisture barrier. The dermis is the thickest layer, next below that. And then the subcutis is further down. That's where we have our fat and fibroblasts. And so melanocytes are found throughout the body. And I think for patients with cutaneous melanoma, that does not come as a surprise. For patients with uveal melanoma, mucosal melanoma, even acral, where we're diagnosing melanoma on the palms of hands, soles of feet, underneath nails, it can be a little surprising to know that melanocytes are found throughout the body in all these different locations. One example of, these melanocytes make melanin. One example of where the effect of different melanin production is in the spectrum of eye color. And so going from brown to blue, you can see that reduction in the melanin pigment. There's 3 different kinds of melanin. We won't really get into that today, but melanin is one of the primary functions of those melanocytes. And so on the far right, you can see UV damage to the skin. That UV exposure causes a lot of inflammation, and that oxidative damage sends a signal into the nucleus and causes a cascade of signaling in the melanocyte, leading to that melanin formation and transfer. And so that kind of comes back to that term of there's no safe tan. Folks that will say, oh, I need to get my base layer. There's nothing safe about that. That's still your body's signal that it's been exposed to UV, had UV exposure, and is really trying to protect itself. And so what is UV radiation? And, certainly I've seen things in the news about how, UVB or UVA is, one's actually healthy and we need it. But it's all UV radiation, and still should be something that we need to be protected from. So you can see the difference in the energy and wavelengths between the gamma rays, X-rays, UV, and then down to the visible light. So the strength of UV rays reaching the ground depends on the time of day. So it's strongest between 10 to 4. The season, obviously strongest during spring and summer. Latitude, stronger closer to the equator. Altitude, stronger at higher elevations. So out in Denver, where Dr. Wade is, if you're out climbing mountains, that UV exposure is certainly going to be higher. Cloud cover may block some UV or reflect some, but even on a cloudy day, you can still get UV exposure. And then surfaces, UV can reflect off of water, sand, snow, pavement, or grass that can increase the exposure. So UVA penetrates deeper into the skin. This can cause kind of aging of the skin cells, DNA damage. It's linked to wrinkles, but can also play a role in some skin cancers. And UVB, B for burn, is the main cause of sunburn and causes most skin cancers. It does have more energy than UVA. And so the primary concern is that this exposure to UV radiation damages the DNA in those skin cells, and this failure to repair damage leaves cells with increased DNA mutations and chromosomal defects, and that this can cause uncontrolled growth in cancer. And so this is a little technical, but I always like to show this slide to just put melanoma in context of other cancers. And so what is the link between UV radiation and some of the treatments that we're going to talk about today? Well, likely because of that UV exposure and just that damage on the DNA of these cells, when melanoma develops in general, cutaneous melanoma is certainly a far different spectrum than something like uveal melanoma. Melanoma has accumulated one of the highest numbers of mutations in the DNA compared to almost any other cancer. Now, melanoma, if I don't have up here squamous cell carcinoma of the skin or basal cell carcinoma of the skin. Those are also similar, but if you look across other tumor types, such as colorectal, pancreatic, glioblastoma, there's fewer mutations. So what does that mean? It means those cells look very different from the normal cells of your body, and this can, is likely why immune therapy has been so successful in melanoma. And when we specifically look at the mutations, that high mutation burden in melanoma compared to others, for the most part, what we see is the nucleotide change from C to T, and this is classic with UV exposure. And so what are, the other risk factors here for melanoma? So we have the UV light exposure, major risk factor for most skin cancers. Sunlight's the main source, but we're going to briefly talk about tanning beds. And so 90% of skin cancers are associated with UV exposure. And then skin color. So as we discussed, so melanin skin pigment, it is a protective factor. And so you can just see as the melanin in the skin gets darker, there is less sensitivity to UV, less likely to burn, and there is less skin cancer risk. And the risk factor none of us can affect is age. We know that the risk rises with age, but we still can see skin cancers even in young people. And so what are some other additional risk factors for melanoma or other non-melanoma skin cancer? So for melanoma, a patient that comes in, we may just discuss, do you have any history of blistering sunburns, especially as a child or teenager? Sometimes that can be hard to remember. And then other folks are like, oh, if I could go back now, I'd spent most of my childhood out in the sun, not wearing sunscreen, having a number of moles. So sometimes this can be hereditary, but folks that have a number of what we call nevi does increase the risk for melanoma. A family history of unusual moles or atypical nevus syndrome. Having a personal history of melanoma increases your risk of having another melanoma diagnosis, and is why we always recommend close surveillance of dermatology, and then a family history of melanoma. What about those non-melanoma skin cancers that can certainly be bothersome and frustrating, especially for patients that say every time I go into dermatology, they're removing another squamous cell carcinoma or basal cell? Well, we know the presence of actinic keratoses does increase the risk for a non-melanoma skin cancer. You see a picture here, and that's why dermatology does like to freeze these off or remove them. Prior treatment with radiation, so patients that have maybe had another cancer that was treated with radiation. Patients with a weakened immune system, so for example, patients that are on immunosuppression, or particularly patients that have had a prior transplant, and then arsenic. And so skin cancer is the most common cancer in the world. 1 in 5 Americans will develop some skin cancer in their lifetime. And despite this understanding of prevention, melanoma rates have doubled from 1982 to 2011, continue to increase. The good news is basal cell and squamous cell, the two most common types, are highly curable if they're detected early and treated properly. And the 5-year survival rate for people whose melanoma is detected and treated before it spreads to lymph nodes is 99%. And so certainly want to treat squam and basal cells early so they don't have a risk of local recurrence, metastatic development. But unfortunately, most skin cancer deaths are from melanoma, although we're making a significant amount of progress. And then you can just see some of the rate of the new melanomas per 100,000 people based on gender and race. So now that we've finished a little background, just going to dive into sunscreens. So sunscreens prevent UV exposure. We've already discussed a little bit to stay in the shade, try not to get a sunburn in particular, avoid tanning, cover up. And so I think one of the important things is just understanding SPF. And so you can see here with just some basic math here, there's 100 photons, for example, from the sun. Without any sunscreen, 100 photons enter the skin. With an SPF of 15, even, I think in perspective, when they're selling, SPF 80, 90, it feels like SPF 15, maybe there's not much benefit there. It offers 93% protection. And so you can see just such a dramatic impact just by putting on SPF 15. And then SPF 30 offers 97% protection. And so really any sunscreen is better than none. But hopefully this kind of helps you understand that just having some sunscreen on, but there is less benefit as that SPF goes from 30 to 50 to say 80. And then screening is important. And so making sure, and we'll kind of discuss this a little bit later from this caricature here of the ABCDEs of screening. And so this is from the Skin Cancer Foundation, what are the 5 W's of sunscreen? So everyone under the sun. So this is certainly something you can take home, not for you, but also anyone else that you may be with in the summers, vacationing with, coming to your house before you're going outdoors to do activities. Even a SPF of 15 or higher is beneficial. 30 or higher is recommended for if you're going to be outside for most of the day. You really should be putting on the sunscreen 30 minutes before going outdoors and then reapplying every 2 hours. And then all exposed skin. And then how much, I think this is the challenge that's forgotten. It should actually be 1 ounce to the entire body for each application. So the example here was a shot glass full, which I think even myself, that does feel like a lot, but I think it's just a good graphic of like, that's actually how much you need to be layering on. And I think just a helpful reminder. There's only a few exceptions. So if you're less than 6 months old, should not use sunscreen due to to skin sensitivity to the sunscreens. And so for those, for babies, sun protective clothing and shade is instead recommended. Broad spectrum, when you see that, what that means is it does protect from both UVA and UVB. Water resistant, so no sunscreen is waterproof. But what water resistant means is that it's had a tested efficacy up to 40 minutes in water. And when you see the term very water resistant, it was tested efficacy up to 80 minutes in water. And so I'll get a lot of questions, or I see there's can be a lot of debate online of the different types of sunscreen. So they kind of fall into 2 separate categories. So one is the physical filters. And so the examples there are titanium dioxide and zinc oxide. These are kind of the oldest ingredients that have been used for sunscreens. So these create a physical filter that you can see there. And so that allows that UV damage does not get absorbed, but it reflects that UV radiation back off versus chemical. So examples here, the avobenzone and octisalate, these are newer, but newer still, a decade or so. So these ingredients, they absorb into your skin. So you can know after you purchase a sunscreen. I think you can tell a difference. The physical tends to be a little bit kind of whiter, chalkier, giving you that little bit of discoloration, but you can certainly feel it, versus the chemical. It's a little bit more lotion feel. So these do absorb into the skin and then absorb that UV radiation. And so there's been a lot more debate about, are sunscreens safe? And so while the physical sunscreens, because they're not absorbed, they'd be less likely to cause skin irritation than the chemical sunscreens, both types have been tested to be safe and effective. And these have all been evaluated by the regulatory, anything that's for sale in the US has been evaluated by the regulatory authorities. And so when you look at the label, any of these ingredients that you see have been tested. Many of these are now combining both the physical and chemical, but oftentimes you'll be able to kind of turn and take a look and see what the ingredients are. And sometimes it's physical and sometimes it's a chemical one. So it's interesting. So the Skin Cancer Foundation, I think this can be helpful sometimes if you're evaluating sunscreens. They do have a panel of dermatologists that will go in and evaluate sunscreens. And so they'll put a seal. Now the companies do have to submit their sunscreens for evaluation, and I do think there is some cost. So I think I would see this as, an extra step for companies, but if this gives you a little bit more reassurance that they have gone in and done kind of a separate testing, that the Skin Cancer Foundation has recommended sunscreens for SPF greater than or equal to 30. If it says daily use, that means SPF greater or equal to 30, broad spectrum. And if they say they're water resistant, they've actually checked it and have substantiated that. If they do have a recommended active seal, that's an SPF greater than or equal to 50. And this is intended for extended sun exposure. This can be used for baby products. Now, that would generally still mean over 6 months, but like the kids younger ages, broad spectrum and substantiation of the water resistance claims. And then they have a separate seal for sun protection products. And so I don't know about you guys, but I've been seeing this on a lot more things of UV protection for clothing, awnings, hats, eyewear, umbrellas, glass. So you can submit for this seal. That would mean the SPF is greater than or equal to 50. And hats, to meet this recommendation, hats have to have a minimum of a 3-inch brim around the entire circumference and 2.5 inches for size 5T or kids, 5T and below. And so there's now, if you type in UV clothing, these are just a few examples. This is certainly a big area of development. And I think also just a huge advantage, right, to that trade-off between, well, I want to be active, I don't want to have to put sunscreen on. And so UV clothing can be a fantastic option. And you can just see here some facts. So they, instead of going by SPF, it goes by UPF, so ultraviolet protection factor. And that's just how much of the UVA-B radiation that fabric allows to reach your skin. In general, whether it's UV clothing or not, dark or bright colors are best because they absorb the UV rays. Loose is best. Tight clothing can reduce that level of protection, and wet clothing also provides less protection. So if you've got kind of a white, shirt with a logo on it that you end up jumping into the pool and wearing, it's really not going to provide any protection versus, say, like a black long sleeve that's looser that you're able to keep dry and put on. And so UPF 30 to 49 is good, and 50 plus is best. And you'll kind of see that on some of these clothing advertisements. So just a brief word on tanning. We are certainly making a lot of progress, and we really think a lot of the interventions should be targeted at a young age, and really trying to do sun protective education as early as possible. And so there's been a number of studies that have shown that the percentage of adolescents using indoor tanning in the past year at the time of the survey has significantly dropped since 2009. So you can see over this 10-year period, went from 25% of adolescents to nearly 5%. And studies have demonstrated that teens who do not tan before age 18 are 2 to 4 times less likely to tan as adults. And so outdoor tanning, though, unfortunately, is now more prevalent in adolescents. So 15% still do outdoor tanning versus 3%. And a third of US adults reported intentional outdoor tanning in the past year. The biggest risk factors were women being aged less than 25, and if they participated in activities near water, physical activity, or work around the home. And so these are certainly areas that we're still trying to target in the field to try to help these folks understand, right, what are the risks, and trying to make good decisions at an early stage in life to prevent any of these cancers or issues later. So just as I wrap up here, just a few slides on some early detection. I'm sure everyone here is aware of the ABCDEs, but I think still certainly just good to go through. So because if we can't prevent melanoma, we can at least try to detect it early. So the ABCDEs, A is for asymmetrical, one half looks different than the other. B, irregular border. C, if its color is variable. D, if its diameter is larger than a pencil eraser, so about 6 millimeters. And E is if it's evolving, right? So if hey, this is a lesion I've had since I was a child, but now, it's itching, it's bleeding, I'm starting to see it's expanding. And melanoma, though, while we have these kind of classic categories and characterization, melanoma can have many different appearances. And so always, if there's any lesion of concern, making sure that you're having it evaluated by a dermatologist. So self-skin exams, though, there's been a little controversy, but I think certainly for this audience, maybe clarifying. So the USPSTF, so this is the government agency that makes screening guidelines. They had recently renewed that there is not enough evidence to endorse asymptomatic adolescents or adults from doing annual skin exams and going into the clinic for this. But I think it's important to know that this does not apply to anyone who does not have any signs or symptoms of cancer, anyone with a personal or family history of skin cancer, and then anybody who meets those ABCDEs. And so it was a little challenging because this caused a lot of headlines of, oh, well, we don't need to do skin exams. But what they're saying is just if you have no symptoms, no personal or family history, and don't meet any of those guidelines, the government is not endorsing that there's enough data to say that you should go get your skin checked. But really, there's a lot of kind of loopholes in this, and anyone with personal family history concerning lesions should absolutely go in and get annual skin exams. And with the skin exams, especially for folks that have a number of different lesions, there's a lot of technology under development. These are some examples of mole mapping, being able to track some of these lesions that may be characteristic for a patient, but really want to be followed. And then a shout out to the OHSU or Oregon team, I know really led by Dr. Sancy Leachman. This is the Mole Mapper tracking app that I believe is free to use and is one of many that I think are really trying to use digital technology to try to help patients be able to track their lesions, help their providers be able to follow these closely. OHSU also has an online education if you wanted to learn more. It's a free module for melanoma early detection that you can go to the link below, be able to click on and kind of educate yourself from their dermatology team. And other things for skin cancer prevention, there's been a number of kind of studies in trying to look at things like beta carotene, unfortunately no evidence, retinoids or vitamin A compounds, because we know that this can be helpful in preventing skin cancer for patients that have xeroderma pigmentosum. But unfortunately for the general population, no data to support that. Vitamin B3, there's been some mixed results showing maybe this can decrease actinic keratosis formation by delaying that, but a higher risk of non-melanoma skin cancers after treatment. Selenium may decrease basal cell, but may increase squamous cell. So you can see we start contradicting ourselves. And then telecoxib, it's a specific NSAID, did slightly decrease recurrent basal cell squam in those with prior disease, but can increase cardiovascular issues. And so just a quick word on genetics. When we think about melanoma prevention, we are learning more about, beyond the characteristics of, oh, I have a family history of melanoma, so I need to get my skin checked, or I've had a history of 2 melanomas and I'm fairly young, or I have 2 cancers now, including melanoma. And we are learning more about a number of syndromes listed here, like Li-Fraumeni-Cowden syndrome. So Li-Fraumeni is associated with TP53, Cowden syndrome with P10, and then BRCA, and then certainly learning more about CDKN2A mutations. And I kind of highlighted that here because patients that do have a history of 2 cancers, insurance in general pays for genetic testing. That can either be that it's ultimately a blood test, but if it's unclear, you can meet with a genetic counselor. They'll go through a patient's history. They kind of diagram it out, like shown here in the bottom right, of who's been affected, what age, what types of cancer. And this can be helpful for some patients just to really understand their risk, not only of melanoma, but maybe other cancers. And I included here our medical oncology guidelines for CDKN2A. You can see that with this mutation, the absolute risk of developing melanoma is 28 to 76%. And these are patients that also have a high risk of pancreatic cancer, potentially depending on their mutation, sarcomas. And so it can be helpful to just talk to your provider if you have a history of multiple cancers or a very strong family history of cancer to see, should I be getting tested? And so ultimately our goal is primary prevention in melanoma and skin cancers. So early UV protection, identifying high-risk individuals so we can do close surveillance and really diagnose any of these kind of atypical lesions or melanomas early on while they're still very curable. And so I would be happy to answer any questions at the end of our session today. So go ahead and submit them into our Q&A, and we would love to circle back on those. Fantastic. And so now that we're now going to switch over here to personalizing your melanoma treatment. So I'd like to introduce Dr. Amatruda, a wonderful medical oncologist up at Minnesota Oncology.
Thank you so much, Meredith. Let me see if I can share my screen. Are you seeing that?
Yes.
Yes.
Great. Okay, good. Well, I really appreciate the opportunity to take part in this session. It gave me a chance to think through some of the aspects of cancer treatment that I've encountered over years. I started medical oncology back around the time gene cloning was invented. So it's been a wonderful change over the years. And I've really enjoyed the chance to work with the enthusiastic young people in Meredith's group and Sarah Cannon, who have a passionate desire to improve care of melanoma. So I'm going to talk about personalized treatment for melanoma. And I realize there's 2 aspects of this. There's treatments based on the unique biology and vulnerabilities of the cancerous tumor, and basically personalizing our understanding and attacking the tumor. And there's also treatment decisions based on unique history, strengths, and vulnerabilities and wishes of the person being treated. And I'll touch on that at the end of my talk. I'd like to start by just talking about what defines a cancer cell. The diagram's on the left. The key thing is that it has unregulated growth. It may be fast, it may be slow, it may be very orderly, it may be destructive or innocuous, but the key thing is that it's an abnormal growth compared to normal tissues. Cancers may grow locally, they may spread and metastasize, they may respond in part to normal regulatory factors. Cancers also represent a community of cells. There are cancer cells shown here in the brown, but mixed in with those will be immune cells, fibrous cells, blood vessels, and the cancer cells and the surrounding cells all change over time and change with treatment. The smallest tumor that can be detected on a PET scan or CAT scan is about 5 millimeters, and yet that tiny tumor may contain more than 10 million cells. And that explains some of the difficulties in treating this disease, because successful treatment requires essentially an extinction of an entire population of cells. Cancers from a given tissue have characteristics of that tissue, and these can sometimes be used to treat the cancer. One of the earliest examples is that lymphoma cancers express a surface protein called CD20, shown here on the surface of a lymphoma cell. And antibodies were developed that bind to that protein and bring immune cells close to it and also recruit attack by other parts of the immune system. And this is a treatment that's been used for many years now called rituximab. More recently, a modification of this approach has been developed where antibodies are developed that bind to surface proteins and also have tagged onto them potent chemotherapy medications. So the chemotherapy medications are attracted just to the target tumor, bought inside, and can kill the cancer. And this is a growing area of medicine, essentially personalized to the particular surface proteins present on the cancer cell. So another aspect of cancer cells are in a hurry to grow. They don't repair damaged DNA, or they can't repair it. For example, Burkitt's lymphoma cells always have to grow. And so if you give them chemotherapy, they all die. And short course intensive therapy for Burkitt's lymphoma works on the principle that the cells cannot repair their normal DNA, whereas normal cells can stop growing, repair the DNA, and some cancer cells cannot do that. So that gives some of the principles of cancer therapies. The first is to remove the cancer before it recruits a blood supply. And that gets back to what Meredith talked about. For melanoma, one of the most important things we find is for people to get in quickly to dermatology if they have a mole that concerns them or a changing mole. And we found that the dermatologists have helped us a great deal by setting up short interval visits where somebody can come in and just have a mole looked at. It takes months to get in for a full dermatology appointment, but you can get in for a week. If you say, there's a mole that's changed or is bleeding or is giving me concern. So surgery is the key aspect. Another aspect is to target the behavior of the cancer cell and essentially damage the cell more than normal cells. That would be with chemotherapy or radiation therapy. And in the old metaphor, the treatment of cancer would be slashed with surgery, burn with radiation therapy, or poison with chemotherapy. Grim, cynical, but it's a lot easier to be cynical when you're not faced with a growing cancer. And these treatments above have prolonged lives and cured many cancers. However, many cancers like melanoma are more wily. They can mutate to become resistant to chemotherapy. They rapidly engage with blood vessels and can spread into the body. And if you remember Meredith's diagram, the melanocytes move into the skin and sort of are visitors to the skin, and they have the capacity to travel through the body because they originally came from the neural crest of the embryonic system. So that's why melanomas are much more dangerous than other skin cancers. They have the propensity and the ability to travel in the body. Cancer cells can also go into rest phase to hide from chemotherapy, unlike the Burkitt's lymphoma cells. And remember, if there's 10 million cells in a little focus, only a small proportion have to survive to give trouble. So one aspect of personalizing the treatment of melanoma is the surgery. So the type of surgery done for melanoma is based on the depth of invasion of the tumor to remove a certain margin of normal tissue around it, and then to look at the lymph nodes that drain that area of skin, really for any melanomas of greater than 0.8 millimeters in depth. Shallow melanomas of stage 1A can just be followed by dermatology without a need for medical oncology follow-up or imaging because they're very unlikely to recur. However, deeper melanomas, we often consider ultrasounds and CT scanning to look for recurrence, and we often will consider immune therapy to prevent recurrences in these higher risk stage 2C and early stage 3 melanomas. Stage 2 and C melanomas are basically deeper melanomas in the skin. Stage 3 melanomas are melanomas that involve the lymph nodes. Now, wouldn't it be better? Can we do better at predicting the risk of relapse after surgery? And there's been work recently on developing gene expression profile tests that essentially fingerprint the tumor to predict the prognosis. There's a Castle test, there's a Merlin test under development. These tests can guide intensity of the follow-up and potentially guide the use of other therapies to prevent recurrence. And this is just a slide, and I'll sort of take you through the slide a little bit. Many of you will be familiar with this. This is a curve that shows the results of how many people, what proportion of people have a recurrence of the cancer over time, 2.5 years, 5 years, 7.5 years, 10 years. This group of people in the blue, identified in the blue line, had a low risk gene expression profile and stage 2 melanoma. These people with the brown line had a higher risk pattern of expression. And what you see is that by 10 years' time, about 75% of people with the low risk pattern are free of melanoma, whereas only about 50% of people with a high risk pattern are free of melanoma. So if we can use these tests, we may be able to follow these people without further immune therapy, yet these people may be benefiting from other therapies to try to prevent recurrence. And work is underway to refine these tests to get a more personalized understanding of the risk of melanoma at the time of diagnosis. But what about, can we treat cancers better by knowing and targeting their mutations and their growth pathways? And this slide here shows that the normal, I can't really read the top of it, the normal growth patterns of melanoma, normal growth control pathways in cells are disrupted by genetic mutations in cancer cells. Different types of mutations cause abnormal growth. One would be an oncogene, where mutation results in a growth signal, essentially an acceleration, like a broken accelerator on a car. And one of those would be the BRAF mutation in melanoma, which I'll talk about in a second. Another type of mutation is a tumor suppressor gene, where mutation results in loss of a growth inhibitory signal, kind of like the loss of brakes in a car. Other mutations exist: gatekeeper mutations, mutator mutations. Basic class of mutations that cause growth of a cancer would be called a driver mutation, and mutations that occur as a result of the cancerous changes would be called passenger mutations. Why is this important? Well, melanoma has phenomenal numbers of mutations. It was referred to as a shattered genome, with this showing the proportion. This is the slide here. Each of these little columns represents one person's tumor with melanoma. And what you see is that the number of mutations in a given bit of DNA is extraordinarily high with melanoma. 10 is a high number for most cancers. Some of these melanomas have 80 or 100 mutations. And within those mutations, most of them were in one gene called BRAF. Another proportion would be in a gene called NRAS. Now, interesting thing about the BRAF is, what this will show here. This is the pathway that's most important for understanding treatment of advanced melanoma. Receptors on the surface of a cell will give signals through the NRAS protein lead to activation of BRAF, and then downstream activation to other proteins, and eventually lead to growth of cells and abnormal growth. Now, if you have a normal pathway, the growth factor stimulates the receptor, it activates this pathway, and the cell grows when it should. And then when the growth factor goes away, the whole pathway goes back to a resting phase. It's like a switch that's turned on and then turns off appropriately. When you have a mutated BRAF protein, it's as if a switch is stuck on. So the cell is growing, giving these signals to the other proteins, regardless of whether it's supposed to be growing or not. And the importance of this in melanoma is that that protein is involved in the growth of many melanomas. The mutations within it have been identified. They cause us a predictable change in the structure of the protein. So it's a driver mutation, and researchers were able to understand how the protein changed shape, and it was possible to design a drug that could be taken in a pill, fit right into that active part of the protein and shut it down. And what you see here up on the right is what happens if you treated cells with this mutation with the inhibitor. This shows the growth over time in an experimental model. What you're seeing here is the cells don't grow, whereas if they were not treated, they grow steadily. This shows another set of melanoma cells that did not have that mutation, and they grow regardless of whether you have this drug present. And this shows a principle of treatment of personalized medicine, which is selectivity. The drug works in the mutated cells. It doesn't affect the unmutated cells. And the benefits are dramatic. So these have led to, this was the first revolution in the treatment of advanced melanoma. And before I go into it, I want to step back and say, how do you know? How does your doctor know that a treatment is helping? Well, they know it through a clinical trial. And this involves treatment of a group of people in a uniform way and seeing how they do. You can't tell if a treatment's working from treating one. You can tell from one person. You can't tell if it's going to work for the next person unless you have data from a group of people. Dr. Yorio is going to talk about this. And then the question would be, what do you measure when you decide how a treatment's working? What's the most important thing? Well, it's easy to measure the response rate when you look at a tumor. You can see that within 3 to 6 months. Then how long does the response last? Is it clinically meaningful? Does this treatment keep the cancer from progressing? How toxic or difficult is the tumor? How does it influence the overall survival? But note that this can be influenced by later treatments. Maybe the most important thing for a person facing a cancer is how long will you live and how will you feel from either the cancer or from the treatment. So let's see what BRAF mutations did. Treatment of BRAF mutations with BRAF inhibitors. Well, they led to a phenomenal decrease in the size of the tumor. This curve is what's called a waterfall plot, and it shows the results of treating, probably 500 people. Each person's tumor either grew or got smaller, and the curve here shows it getting smaller until even in some cases, it completely disappeared, decreased by 100%. No treatment for melanoma had ever had any benefit like this. And this treatment can lead to control of the melanoma over years. This curve shows the likelihood of being free of progression of the melanoma over months, 12 months, 24 months. And what you see is that and each time somebody progresses, this curve ticks down a little bit. So about 50% of people are free of progression for a year. And unfortunately, then it has come back in these people. but about 20% of people may be free of progression out to 5 years or longer. This is for treatment with a combination of the BRAF inhibitor and the MEK inhibitor. And MEK is this next step in that treatment pathway, in that signal pathway that I showed you. We give them together because two together, I'll go back a little bit, two together inhibit this and inhibit this, decreases the rate at which the cancers become resistant to the treatment. So giving them together. It's also possible, so this is a summary here. Who's more likely to have long-term benefit of this? People with a low LDH, which means their cancer is not growing quickly, who have just a single site of spread of the melanoma. We look at the overall survival of these treatments over time, but most people are treated with more than just one treatment. So it's hard to conclude how the BRAF inhibitor alone is affecting the overall survival. But we do know that it does reduce the risk of progression for at least a year in most people. Which ones to choose? There's 3 different combinations of BRAF and MEK inhibitors, and they all have about the same degree of effectiveness, about a 68–70% response rate, and duration of response is about the same. They differ somewhat in toxicity. Dabrafenib and trametinib often causes fever that can be disabling. Vemurafenib can cause severe skin rash and diarrhea. Encorafenib can cause muscle aches and occasionally some eye changes. Often we try one, and if the toxicity is too high, we might change to another one. It's also possible to use these to prevent recurrence after surgery. And this is a slightly different approach. This is after removal of all the tumor, but knowing that it's a high risk of recurring, we can give these to prevent recurrence. Usually, the treatment to prevent recurrence is the use of immune therapy. And Dr. Wade is going to talk about this a little bit. However, if there's a rapidly growing tumor with a high LDH, or if a person has impaired immunity, the use of the BRAF inhibitors may be used to prevent recurrence. What we see is that it does prevent recurrence in many people. It's given for 1 year. That's this curve on the top in the blue. And then over the next year or two, there is a higher risk of recurrence. But still, out to 5 years, more people are free of recurrence who are treated with these treatments in comparison to people who did not have those treatments. Now, what Dr. McKean has pointed out in some of her previous talks is let's look a little bit at these segments. What is the value of our treatment? Well, these people who had recurrence, we need to treat them better. We need to find better ways to treat. So about 40% of people, we need to have a better treatment to keep it from coming back. These people, about another 40% of people, did okay even without the treatment. So it's in that we've improved the odds by about 20%. Now, this is a substantial improvement. We need to do better. We need to be able to move this curve up and make it so that fewer and fewer people have recurrence. It prevents distant metastasis, generalized recurrence, and also distant metastasis. And so what else can we do? I'm going to review here. So we want to improve on this. So how could we improve it? Well, let's review again where the mutations are that we know. There's NRAS mutations. There's mutations in the BRAF protein, the one that we talked about. There's other mutations in the BRAF protein. There's mutations downstream of that in other proteins. One possibility is to target other BRAF mutations with naporafenib. That's a new agent which is under development. And if we look at that, we see that it also has the same benefit in terms of reducing the size of the tumor, but it's not as powerful as the BRAF inhibitor was. There's fewer people who have that profound reduction in the melanoma tumor size. There are agents that bind to the BRAF, to other mutations in BRAF. This is a summary. NRAS mutations are being looked at. Pan-RAF inhibitors will work against non-consensus BRAF mutations like I've shown here. Eye melanomas, which are a very different type of melanoma than skin melanomas, can be treated with agents that stimulate protein kinase C, that block that rather. Research now is looking into understanding the biology of the melanoma. What makes it grow? What makes it invade? Why does resistance develop? Why do melanomas get so much energy from sugar? And can we use that against them? Sometimes melanomas recur 10 years after the original tumor was removed. Where is it hiding in the body? Why doesn't it grow during that time? What makes it start to reappear and grow? I referred briefly above to other personalized medicine strategies, such as the use of antibody drug conjugates, in which a chemotherapy loaded antibody will bind to a protein on the surface of the melanoma and then attack the melanoma. Studies are undergoing now with a TROP2 antibody drug conjugate. So I don't want to run too much time here. The problem we run into is that our treatments stop working within about a year in the case of BRAF inhibitors. And why does that happen? It happens because you have 10 million cells. And those cells that are sensitive stop growing, but unfortunately the cells that are resistant become a dominant population. So God, in designing melanoma care, God might be saying, only 1 year of benefit. What can we do to treat it better? Well, we know it's a disease of growth regulation. In some cancers, the key genes can be identified. In these few, the genes can be inhibited by drugs. What do we do? What if we wanted to know everything possible about a given cancer? What if we wanted to define all mutations which affected the coding regions of the genes involved in cancer? What we would do is we would sequence all the DNA. And this is what came out of the Human Genome Project back in 2000. And it was a revolution in our understanding of cancer. But unfortunately, there's still limits based on understanding all the genomic mutations in a cancer. Even if we know those mutations, we don't fully understand how they interact. The Human Genome Project really just gave us the parts list for a very complex organization of a cell. It didn't explain how everything works together. And what you see is that growth control pathways are incredibly complex and interactive. This is just for one growth control system. There are dozens of other growth control systems. So it's a bewildering degree of complexity. Also, there's another problem. The gene mutations we can treat with targeted therapies are mutations that activate proteins and cause abnormal growth, like the struck accelerator in a car. So we can give a drug that turns off that growth. But most mutations that cause cancer are in tumor suppressor genes, where the mutation essentially inactivates a growth control gene, kind of like the brakes failing on a car. And the problem with that is that we don't have a good way to replace a failing gene or replace its function. Also, even if we did replace the gene and made that cell grow more slowly, that cell would then be outgrown by any resistant cells, which did not respond to the replacement of the tumor suppressor gene. So presented with this complex and terrible picture of a much more wily and evil cancer cell than our poor brains can deal with, what can we do about it? Well, one solution is this: as cancer cells grow faster, become more resistant to treatment, they also become more mutated. Their genes and proteins become more abnormal. The cells become bizarre and weird. Well, then they may be more visible to the immune system, if only the immune system can be awakened. And Dr. Wade is going to talk to you a little bit about that and how that can be done. So I wanted to briefly, before I leave this, talk about another aspect of personalized treatment, which would be the person. We were talking all about the unique characters of the cancer. What about you, the person being treated? Well, we know how to treat based on clinical trials, which are treatments for a group of people, all with uniform characteristics. If a doc proposes a treatment for you, you should ask, how well does a clinical trial match my case? For example, stage 4 melanoma can be very extensive disease, or it can be just a single distant metastasis. Did the treatments work the same for people with extensive disease or oligometastatic disease? What strengths and vulnerabilities do I bring to the treatment? If I have an autoimmune disease or an immunosuppressive treatment, immune therapy may not be safe or effective. Then maybe targeted therapy would be better. My body may respond in very different ways. Research now is looking how the bacteria in your gut may influence how you respond to immune therapy, and research is going on that. What choice would you make as a person? Would you choose a more toxic treatment if it increases the chances of remission, or would you wish to minimize toxicity and minimize risk? A choice you have to make in talking to your doctor or your practitioner. Are there aspects of your care that fall outside of our clinical trial knowledge base? Clinical trials look at a uniform population of patients and are very valuable in defining what treatments to do, but they can be blunt instruments. They may not fully account for prior treatment. They may not account for the fact that somebody has a single metastasis that can be treated with radiation or brain metastasis. Also, how do you respond? How do you respond to the treatment? How does that guide what you should do? How long should you be treated? When should you change treatment? Are you having a response on X-rays, shrinkage of tumor, or is it possible that you're having not much response on X-rays, but your tumor is shrinking down when we biopsy it? And we certainly see this in melanomas. So all of these are questions that you should bring to your doctor when they talk to you about treatment, essentially part of the art of medicine, helped by clinical trials, helped by your understanding of the biology of the cancer. And I'll stop now. So thank you for listening and giving me the chance to think this through.
Well, thanks, Dr. Amatruda. That was fantastic. I loved, we always talk about how these pathways are just so simple, right? It's just one thing to the next. And so I loved that picture of just actually showing, like, for every, cause, there's a reaction, and things are certainly more complex. And then I think you're right. We have all these trials, but what does that mean for you as the patient and your discussions with your doctor? So that was fantastic. We will now move on to Dr. Waite. So Dr. Waite is a medical oncologist, a medical director at the Melanoma and Skin Cancer Institute and Sarah Cannon Research Institute at Health One, coming to us from Denver, Colorado. And he'll be presenting on Immune and Cellular Therapy 101. No easy topic, but looking forward to your discussion, Dr. Waite.
All right, excellent. Well, I hope that you can see my screen. Is that working, Meredith, on your side?
Yep, looks great.
All right, excellent. Well, thank you to Dr. McKean for the introduction and hosting today. Thank you, everybody who's participating and joining from around the country. And Dr. Amatruda, thank you for the excellent preface to this immunotherapy talk. And then we have Dr. Yorio coming up thereafter. So I'll certainly do everything I can to stay on time today. It's a pretty significant task, I think, to talk about immunotherapy and melanoma from start to finish. And I don't think that's the goal today. I think the goal is really to talk about the mechanisms that we think of when we're using immunotherapy and melanoma and even other types of cancers. And so I'm really going to focus on the key principles in terms of how our most common therapies are used. And I also want to talk a little bit about adoptive T-cell therapy, which is recently approved for the treatment of melanoma, as we'll talk about, but also, there's a lot of growth and development in cellular therapeutics in general, which includes adoptive T-cell or TIL therapy. So we're going to focus on those two topics, really. And I'm happy to give this today because this is one of my favorite I guess you could say lectures or talks to give, especially to medical students, residents, and fellows, and people who are in training and first learning about immunotherapy. So this is a brief comment and a little bit outdated, but I think it's pertinent because this is from 2015. And so if we look at melanoma survival, even back as recently as 2015, let's call that 10 years ago, you can see that the overall survival at 5 years was still fairly low at that time, even after the approval of some of these newer immunotherapies, and other cancers really had a very low survival rate once it was metastatic. And so this was one of the driving forces behind all of the developments that you've heard here already today, immunotherapy and targeted therapies included. If we look at the cancer treatment modalities we have available to us, we have chemotherapy and targeted therapy. And targeted therapy, Dr. Omatruda just gave us some insight into. We have radiation, we have surgery, we have immuno-oncology. These are all separate approaches and separate treatments that I think should be thought of as such, but can be used in combination in a sort of a multidisciplinary approach to treatment of cancer care, including melanoma. So we're going to focus on the lower right puzzle piece, which is the immuno-oncology piece today. So when we talk about immunotherapy, that term gets used a lot, and it actually encompasses a wide variety of topics. As listed here. And I think it's easiest to digest when we separate it into two categories, active immunotherapy versus passive immunotherapy. So active immunotherapy is going to be things like vaccines and cytokines. And we're going to talk specifically about the one on the right, which is an immune effector cell modulating therapy or immune checkpoint blockade. That's really what we're focusing on in terms of our mechanism of action, because that's what we use the most of in our clinical practice. And then the passive immunotherapy is certainly not to be ignored, very important. This would include, these treatments are not designed necessarily to act directly, or are designed, to act directly on the tumor as opposed to the immune system. And so that would include our adoptive T-cell therapy or our TIL therapy, which we're going to talk about. So the two we've highlighted are what we're going to talk about today. This is a fun cartoon that I like to use to sort of highlight where we've come from in immunotherapy. So going all the way back to 1891, we have documentation of the first cancer vaccine in quotation marks, demonstrated by Dr. Coley when he was essentially injecting bacterial toxins into patients that had mostly visible tumors or cancers, because things like x-rays and that sort of thing were not widely available or developed at the time. And he noticed that these tumors that could be visualized on the skin would sometimes get better if you injected these patients with bacterial toxins, or essentially infecting them with bacteria. And what we now understand, although they didn't understand it at the time, is that we were inducing an immune response. Our immune system was responding to the bacterial injection and was then cross-reacting, if you will, or better equipped to fight the cancer at the time. And so there were some successes with that approach early on. And then you can kind of just read through as we've moved into the 1960s and interferon in 86, and then a prostate cancer treatment in 2010, which was really the first cellular immunotherapy that was approved. And then starting in 2011, brings us into the modern era, if you will, of immunotherapy with the approval of ipilimumab in melanoma. And melanoma has really led the way for a lot of these developments, and led the way for other cancer types. So this really talks about, this is just highlighting some of the articles at the time when these immunotherapy, immune checkpoint blockades were first being developed. So it was in Time magazine, and it was the breakthrough of the year in Science magazine. The person on your top, the handsome gentleman, I should say, on your top right, is Jim Allison, who was a pioneer in the development of these immune antibodies, specifically CTLA-4, and went on to win a Nobel Prize for his work. So this is what I really want to get to. This is the educational piece, kind of talking about how these work. And I don't know if people on the call have heard some of this before, but we really have to understand the immune system. So two different types of immune response. There's an adaptive response that comes in a little bit later after the initial insult, if you were to have, say, a bacterial infection or pneumonia. Then there's innate immune response. So the one that comes in initially and you get that initial increase, and that's maybe fevers and chills and flu-like symptoms and not feeling very well. It's really the adaptive response that we want to focus on. That's when we're creating our antibodies against, these pathogens, whether it be bacterial or viral infections, for example, or we're expanding our T cell populations to better fight these infections over the long term, and even to recognize them into the future and prevent them from reoccurring. So these T cells come in two different flavors. We're going to focus specifically on the T cell component. You have cytotoxic CD8 T cells, and you have helper CD4 T cells, and those are our main compartments. Both of these cells, these two different T cells, CD4 and CD8, expand in response to a stimulus. Again, I'm going to use a bacterial infection as a very common stimulus. And so they clonally proliferate. They basically make clones of one another, and they expand out in both of these two cell populations that are then eventually controlled once the infection or the insult is under control. And that's how our immune system responds to various types of insults. And in a way, it's how it responds, or how we need it to potentially respond to the growth of a tumor. And so this is a little bit more complicated slide, but I'll focus on the 2 points on the right. The human genome, just to put this into perspective, has about 20 to 25,000 genes. That's a lot of genes in the human genome. But the number of things, the number of items or proteins, let's say, that the immune system can recognize is nearly nearly 10-fold that. So 10 times the amount of genetic code that we have, or genes that we have, are the number of receptors that the immune system can create or generate to recognize bacteria, viruses, etc. So the success of our immune system against an infection or against a tumor is really predicated on how diverse it is and how much it's able to recognize, or in some instances, when we talk about cancer, unfortunately not being able to recognize the cancer as foreign. And so what happens when our immune system is activated is that a professional antigen presenting cell, so a cell that is its sole purpose is to present an abnormal protein from a bacteria, a virus, or a cancer cell to the immune system. So those are things like our macrophages and our dendritic cells. And that's what the professional antigen presenting cells are meant to do. That is their purpose. This little red dot here in the center shows the protein that's being professionally presented by one of these immune cells to another immune cell. CD4 T cell on the right, CD8 T cells on the left. And this schematic is just highlighting there's some functional differences between the two in how they're recognized and how they're presented. So here you see the same cartoon. And so what we see here is that the initial recognition of that little red dot, that protein, we're going to call that signal number 1. That's a T cell receptor signal. So that's receptor number 1. The key in understanding how immunotherapy works in cancer is understanding that you have to have a signal 2. You have to have 2 signals to activate a T cell. You have to have both. What you can see here is that if you only have one signal, the T cell is anergic, it's not active. If you just have the second signal, it has no effect on the T cell. You have to have both in combination. So it's signal 1 and signal 2 that's needed to activate the T cell. Now, if you have both signals, the T cells proliferate, like I showed you, clonally, they increase in number, and then they become effective to attack whatever they're trained to recognize. So that's what we call effector function. So it's attacking, in this case, virus-infected cells. But the same concept applies for cancer cells. So just imagine these viral infected cells here on the right being cancer cells. The immune system is going to that site, recognizing them as foreign, and eliminating them if both signals are present. So here's the trick. So the signal 2 is not just a single signal, it's actually thousands or hundreds of thousands of signals that are constantly interplaying, tugging, pushing, and pulling on the immune system. So back in 2002, where this cartoon came from, we understood a number of these interactions that made up signal number 2, and you can see the effects are either positive or negative on the, or unknown on the immune cell. So this is what we knew in 2002. Fast forward to 2015, and we understand that there's actually thousands of these signals that are constantly at interplay with the immune system at the level of the T cell. So what it becomes is a summation of how many positive signals you have versus how many negative or suppressive signals that you have on your T cell or on your immune system. And so it's a balance between the brake and the gas in terms of how active the immune system is, that would be turning on the gas, versus how inactive it is, and that would be pushing the brakes. So it's a really, really complex system. And so here's a schematic of a T cell, one of those immune cells, interacting with all these different, here's your professional antigen presenting cell, here's your tumor cell, and here's your macrophage, which is another antigen presenter cell, professional cell. And so the T cell can be acted on by all these different factors all at once. But we have gathered or developed drugs that can block some of the negative signals that make up signal number 2. So you see these red X's appearing. These are some of the interactions that we've developed, antibodies or drugs, which block that handshake, which block that agreement between the T cell and the tumor to not be active against it. And so if we block enough of these negative or down-regulating pathways, then the T cell or the immune system is able to be more active than it would otherwise. And that's the concept of the gas and the brake. So balancing the gas and the brake. You want to have, in terms of cancer treatment, you'd like to have a little bit more of the gas, a little bit less of the brake. So what we're actually doing is we're eliminating or pulling back on the brake on the immune system and allowing it to be more active by blocking some of those negative signals. So that's the way we should really be understanding how these immune checkpoint blockade drugs, which have been developed and available since 2011, are working in melanoma and other types of cancers. So when it comes to tumor cells, here's a cartoon of how the PD-1, the T cells interacting with the T cell. Here's your signal number 1. Here's the protein presented to the T cell on the tumor. And then here's that negative signal number 2, the PD-1 interacting with the PD-L1. And again, that's an agreement between the tumor cell and the T cell to shut down the function of the T cell so that it can't attack the tumor. But if we block this one interaction here with an antibody, that being the little red triangle, then the T cell is able to recognize the tumor cell and kill the cell. So that's the function of these treatments, and they work really well. People like to see pictures. Here's a CT scan of a patient with tumor, which is this big sort of conglomerate mass here that we see. And here's another tumor that's quite large in the liver. The rest of the things you see here are actually normal. And after treatment with a number of immunotherapies that we just talked about, you can see that that big mass has disappeared completely, and the liver mass has also disappeared, no longer present. So these can be very effective treatments for certain individuals with melanoma, such as in this case. So if we look out to where we are today, this would be sort of our landmark study that looks at the combination of 2 of these immune checkpoint inhibitors and how we're doing 6.5 years out after the initial treatment with these 2 immune therapy drugs that we just talked about the mechanism of. This data has since been updated to 10 years, and I'm just showing you the 6.5 year, but it's similar, I will say, at 10 years out from treatment, which is really remarkable. But what we're seeing here is in the very top line, the very top curve, this is essentially saying that half of the patients who received this combination of immune checkpoint blockade or 2 immune therapies together at the diagnosis of their melanoma, that would be metastatic melanoma, those that need treatment and can't be removed surgically or treated in other ways, we see that 50% of people are alive and in many cases doing very well out 6.5 and then further 10 years out from their treatment, which is quite remarkable. And the other lines that you see here, this is a single immunotherapy drug used by itself, 42%. People do pretty well there. And then this is another single immunotherapy drug. The red line is when you combine the two together. And so we're really doing quite a bit better than we were with melanoma a number of years ago in 2015, as I showed you in the beginning. This pie chart that I'm showing, I think, is important, and there's only one point to take away here, really, and that is that the blue portion of this pie chart are the patients that are treatment-free. So that means the patients are off of treatment, in this case, 6.5 years later, and are alive and well after the treatment. So you can see the blue on the left hand, and this pie chart makes up the majority of the pie chart. So that's patients that are off of treatment after receiving that combination immunotherapy. So not only are they living a long time, but they're also off of their treatment in many cases. So let's put it into perspective. Let's see where we're at. So historically, these are the number of patients that were living with melanoma that was metastatic a number of years ago, as recently as a decade. And you can see that that's not many people out here 10 years that are alive with melanoma. Well, when we started treating with the single drug ipilimumab, we see it increased to 20% out at 10 years. That's really great. When we look at our PD-1 inhibitors, let's think about that as maybe the next generation of immune therapy. Nivolumab's a good example of this. When we look out at 5 years, we see about 35 or 40% of patients who are alive and well. And when we combine nivolumab and ipilimumab, we see out at 10 years now that about roughly 50% of patients are alive and well. But we still have an unmet need here for the other 50%, right? Those who are needing other treatments or maybe who aren't living as long. And so in the future, we hope to be closer to 80% and even 100%. And that's where things like adoptive T cell therapies and other clinical trials come into play, looking to see how we can do better. So I think I only have until 10:30, so I'm going to skip over the complications of immunotherapy. But just to say that side effects from these immune drugs have to do with activating your immune system as well. And I always tell patients that in the clinic before we start that when you activate the immune system, we hope that it recognizes the cancer as foreign and eliminates the cancer, but it can also become confused and it can attack healthy organs in the body and cause inflammation in healthy organs in the body. And so these next couple slides, which I'm going to skip over, tell you about some of the side effects that we see with these medications and the incidence of those side effects. It also would tell you a little bit about what we do and don't understand about the side effects, because we're still learning a lot about how the side effects occur. We understand what the side effects are and we know how to treat them very effectively. We're still trying to figure out who gets the side effects and who does not, because not everybody has the side effects from immunotherapy. But I'm going to skip over a couple of these slides because of time, and I'm going to move into TIL therapy because I think that's important to talk about and to touch on, and it's sort of a hot topic right now. So if we look at how TIL therapy, adoptive T cell therapy, works, remember, this is a passive immunotherapy. So this is not acting on the immune system quite as much as it is acting directly on the tumor, but using the immune system to do so. So the way that this is done is we excise the tumor, and in this case, we're excising about 1.5 centimeters of tumor, so it's a small piece, and we put it in a plate or separate it out. We grow out the T cells, and you can see that we can assess for which T cells, which immune cells are in the tumor and how they differentiate from one another. We can then select for specific T cells that we think might be best acting or most likely to act against the tumor in other locations. And then we can expand or grow those T cells in a lab and then use them to treat other areas of melanoma in this particular case. So the process for this is outlined in this schematic. So the journey or the patient journey for TIL or tumor infiltrating lymphocyte therapy is that you have the 1.5 centimeters of tumor collected. We just saw in the last slide this process, how the T cells are selected and expanded. And then the patient undergoes in hospital, often it's in the hospital, a 5-day chemotherapy treatment, which reduces or knocks down the immune system initially on purpose, so that we can give the patient back the T cells that were pulled out of the tumor. So it's a really sophisticated treatment. And then this IL-2 administration is when we stimulate those T cells, those immune cells that we just gave back to the patient. We stimulate them so that they can better activate against the tumor in other locations other than where it was harvested, and in the location that it was harvested as well. So I'm going to skip over this lymphodepletion, but when we use TIL therapy, this is a picture of a tumor just sitting underneath the skin. So that's that bump before TIL therapy. You harvest the tumor, as we talked about, and you treat the patient in the way that we just outlined, where we give the T cells from the tumor back to the patient in an expanded form. You can see that there are very rapid responses in tumors that were previously very hard to treat, and this is a melanoma patient. So here's a picture, because we always like pictures. This one's a little bit harder to see, but this area circled is the tumor. All the other things you see here are normal organs. And 5 years out from treatment, this particular patient has what we would call a normal area of scar from where the tumor previously was after TIL therapy. So it can be very effective, again, for some patients. If we look at how effective it is, this is the original top-line data for the TIL therapy. This is what was initially presented pretty early on. And what it showed was that a number of patients, and what you see here in this waterfall plot, those on the right, any bar that's below the 0 here are tumors that are shrinking in size or decreasing in size. And everything up here on the left that's increasing in size, that would represent a patient that maybe isn't responding to the treatment, or the tumors are getting larger. And so we call this a waterfall plot. And in this particular instance, these patients were melanoma patients that had received many prior therapies, including immunotherapy, before receiving TIL. And those individuals sometimes did not have many other options outside of a clinical trial. And so on this particular clinical trial, you can see that the response rate is pretty good. A lot of these tumors were shrinking down. In fact, about 81% of patients had a reduction or decrease in their tumors. And this therapy, based on this data and some other data, was approved February 16th of this year. So just recently approved and starting to be available widely outside of clinical trials at certain centers that are capable of providing this very complex treatment. This just highlights that about half of the patients, or maybe a little less than half the patients who have a nice response, have it ongoing for a long period of time, and without recurrence of their tumor, or without regrowth of their tumor. And so there's some durability here. This is a busy slide, which I won't go over in too much detail because I'm a little bit over time already, but we're moving this TIL therapy up to the front line. What I just showed you before were patients that were already treated with a lot of other treatments, usually immunotherapy. In this particular trial, and things that are forthcoming, we're actually looking at what if we give the TIL therapy, the adoptive T cell therapy we just reviewed, earlier on in the patient's treatment journey. What if we give it in the first line before they receive any other treatment? And so you can see in the top left, these look, again, another waterfall plot. These are patients who are responding to the TIL therapy prior to receiving any other therapy. And so this is a proof of concept for treating patients maybe a little bit earlier with TIL therapy, and also in combination with one of our other immunotherapy drugs as well. And so trials looking at that approach are ongoing currently, and just sort of activating as we're giving this talk. This is my last slide on TIL. And so this is just highlighting a newer version. Maybe we could refer to this as TIL 2.0, something along those lines, where we are taking those same T cells out from the tumor that we just described, or removing them via a biopsy or via surgery. But in this case, we're actually modifying the T cells. We're not just growing them in a petri dish in the lab and giving them back to patients. We're modifying them ever so slightly. And we call that genetic engineering, or changing the function of the T cell, which our technologies today, which are fairly sophisticated, allow us to do in a very precise manner. And so why would we do this? Well, number one, we want the T cell that we're giving back to the patient to be more effective. And so this is one way to potentially make it more effective. But moreover, we want to try to reduce the side effects of our treatments. And this particular engineered T cell is aimed at reducing the side effects from the IL-2 that we give after the TIL has been delivered. And so this is a really, really, I want to say cool, for lack of a better term. This is a really interesting approach where we can reduce the side effects from the TIL therapy by turning the T cells on and off by using a little switch that we put into the T cells. And so we can turn them on to help them recognize the tumor. And then when the side effects become too much, we might be able to turn it off. And I think that's a really, really sophisticated approach, and more to come on all of these treatments, but really exciting in terms of what we're moving towards. There's lots of clinical trials. This is just a list of a few of them that are currently available. The transplant and cellular therapy locations that Sarah Cannon Research Institute offers are listed here. These are where we are currently providing TIL therapy or similar types of therapies. So you can see Denver, Nashville, Texas, and also Cincinnati included. And those are might be resources for people on this call or people that you may know. And so sorry for going over just a few minutes, but I hope that that was helpful in terms of education around those two topics. So thanks so much for the time.
Fantastic. Thanks, Dr. Waite. I think cellular therapies I feel like just the tip of the iceberg of where we are and where we want to be for patients. And TIL with the recent FDA approval, I think there's still so much for all of us to learn and for patients to be able to be educated on. So I think that was really helpful. Alicia, I think you maybe had a programming comment.
Yeah, let's skip the break because we'll go right into Dr. Yorio here, and it's perfect timing because it's and subject matter switch because it's on clinical trials, and that's where we sort of ended there with Dr. Waite. We'll go to Dr. Yorio. There'll be a few brief words from AIM, and then we'll have our Q&A session. So please, Dr. Yorio, thank you.
All right, thank you so much. Hopefully everybody can hear me. Let me get my slides pulled up. Okay, great. All right, so trying to tackle what should I know about clinical trials? I think clinical trials, obviously, something we are all heavily involved with and something we think is extremely important for our patients and for the future of melanoma treatment. So I always kind of try to take it back to patients and patient care. And I thought back to a patient I had 10 years ago now. And so this patient actually presented to me with metastatic melanoma. And unfortunately, this is her PET scan back in 2014. She had these big bright spots in her liver, and those are large metastasis of melanoma. She also had involvement in her bones and lungs, and so pretty widespread disease with melanoma. And in 2014, we were just on the cusp of a few new approvals for immunotherapy, which Dr. Waite covered, but options were just starting to emerge, right? And so I talked to her even about clinical trials at that point. And we'll come back to this patient here towards the end, but just wanted to kind of throw that out as a patient case because I think that's always important. What are clinical trials? I think clinical trials and research. Maybe the media and Hollywood doesn't always do us good favors. Here's kind of the first thing that comes to my mind when I think about scientists and research. Right, we've got our Back to the Future mad scientists. We've got the Hulk. We've got Frankenstein, and those are kind of images we grow up with when we think about scientists and research sometimes. And I think sometimes that maybe turns people off of research a little bit and sort of has people scared about research. And so I think it's really important to think about what research is and what we're trying to do and why we're trying to do research. This is why we're trying to do research. This is looking at new cancer drugs approved by the FDA just per year over time, and there's just been a explosion per year of new oncology drugs really over this last 10 to 20 years, and this only goes through about 2016, but it's even exploded more over the last 5 to 10 years. And so there's been an exponential growth in oncology drug treatment which is awesome because that means we're getting better outcomes. We're having people live longer, better, free of cancer, or continuing to live even with their cancer. And just amazing to see how much progress we've made over the last 10 to 20 years. And that's all because of research and clinical trials and how important that is. In melanoma specifically, there's just been an explosion, right, of FDA approvals of new drugs. And so you can see on the left, 1974, we had a chemotherapy drug called dacarbazine that we used for advanced melanoma. There wasn't a new really approval for melanoma until 1998, which was systemic IL-2, kind of that first proof of immunotherapy being a treatment for melanoma. And then nothing really started to happen until kind of 2011, and that's when we started to have the emergence of targeted therapies, vemurafenib with the BRAF inhibitor, and then ipilimumab, which was an immunotherapy CTLA-4 inhibitor. And we've just exploded over the last sort of 13 years with lots of new drug approvals. And most recently, TIL therapy, actually 2024 is what that should say. But we've seen that just advance dramatically over these last 10 to 15 years. And that's all because of clinical trials and research and being able to move our bar. And as a result, what you're seeing is people living longer, right? And better and free of cancer. So if you had back in 2009, our overall survival rates with metastatic melanoma were really poor, right? Only about 1 in 20 people survived 5+ years with metastatic melanoma at that time. And now you're seeing over 50%. Of course, we've still got a long way to go, and that's why it's still important that we push clinical trials and find new drugs and better ways to treat people. So what is a clinical trial? Well, it's a research study that's testing new medical treatment or some sort of intervention in people to determine its safety and effectiveness. There's all different types of trials and research trials. There's just plain observational trials. We're just watching and seeing what are happening to people. Interventional trials, which may be some type of therapy, or it might be not a true drug treatment, but some other intervention. For instance, we've got things like, can iPads, help improve, how people take medicines and report side effects and all those types of things, and being able to report that back to us. So, those are also trials, things we look at to see how we can improve patient care. Therapeutic trials, those are going to get the most highlighting the most, because that's where we're trying new drugs, new types of medicines, new types of other treatments to see if we can improve patients' survival. Non-therapeutic trials, again, other types of interventions you could use. Diagnostic trials, right? Can we do better PET scans? Can we do better other treatments? Can we have better things like skin mapping to detect patients' melanomas earlier? And similarly, screening trials, would things like mole mapping be more effective to screen people versus other things? So those are all some of the highlights of different types of trials that can be done, and people can get involved in those at any type of situation where they're at. So when we think hard about true interventional clinical trials, we think about phases of clinical trials. So you'll hear different phases. There's, of course, preclinical trials where we're looking, that's really what's happening in a lab, what's happening when we look at cancer cells and how we look at it under a microscope and treat them with different types of new therapies. It might be looking at mouse models or other types of interventions to see could medicines could compounds be potentially effective to actually make them into some sort of drug. Then that leads essentially into a phase 1 clinical trial. And that's where we've got a new drug, maybe a new drug combination that we're trying to see. First and foremost, is it safe to give to people? Typically, phase 1 drugs are going to start at a very low dose, and they ramp up the dosing fairly quickly, but just to make sure that it's safe to give to people, that there's not too many side effects, right? We don't want to give medicines. We don't want to make the treatments worse than the disease. So we're trying to find out that delicate balance. And that's really where phase 1 trials are focused on. But they're also starting to see, is it effective can you get a signal with different types of cancer? A lot of phase 1 trials might actually be all comers, looking at melanoma and colon cancer and lots of other different types. And then if there's a big signal in melanoma, then we're going to expand that out. Sometimes there's expansion trials of a phase 1 that might get a little bit of a bigger group for a particular type of cancer, just to see if there's more of a treatment response, and also to get more information on safety. Then we move into phase 2 trials. Phase 2 trials are, hey, we've looked at this drug, we've found some safe dosing, we think it's safe to continue to proceed with this medicine. There seems to be enough of an early signal that there's some responses that it seems like a worthwhile thing to continue to pursue. And so phase 2 trials are going to be a lot more patients, but usually anywhere from 30 to 100 or 30 to 200 sometimes patients. So it's a bigger group, and we're really trying to see, is it effective? And we continue to look at safety as well with a bigger group, make sure there's not any other adverse events that we didn't capture in the phase 1 trials. Most of the time, phase 2 trials are going to be getting that intervention, maybe that intervention plus a standard of care, those types of things. Then we move into phase 3 trials. They're much bigger studies. They're usually comparing whatever this new therapy is to a standard of care, or as I said, it might be that we're comparing, this with the standard of care versus just the standard of care. And so those are much bigger trials, and those are what usually lead to an FDA approval of a medicine. And then there are phase 4 trials, which are kind of like a look back. Medicine's already been approved. So let's say ipilimumab and nivolumab got approved, and we run a phase 4 study just to really monitor safety when we're looking at a much bigger population. So that's really a treatment that's already been approved, but we're continuing to monitor safety, because to us, that's by far the most important thing, is we want to make sure medicines are safe for people. Which leads us to this: are clinical trials safe? A lot goes into clinical trial research before a new drug ever is given to a person or a patient. And that's things called institutional review boards. So IRBs are very focused on safety. They want to make sure a new medicine is safe. They want to make sure a protocol is safe and it's being done right. And so there's each sort of research institutions have their IRBs that really are focused on safety and reviewing protocols. Informed consent is extremely important, right? We want to make sure that patients know what they're signing up for, what the purpose of the study is for. And so that's a very important thing. It's not, we don't want to just, people shouldn't be guinea pigs ultimately. They need to know what they're dealing with and why they're getting on a clinical trial. And so that's why informed consent's so important. And we're always weighing those benefits of the potential benefits of a trial versus the risk. And it's important that, your doctor talks about those, the person running the clinical trial talks about those, and constantly is making sure that these are safe for people ultimately. The other thing we hear a lot about is placebo. People get scared about a clinical trial because they think, well, gosh, you're just going to give me a placebo. And so what is a placebo? Well, that's usually not a true medicine, right? It's going to be a pill that doesn't have any activity, or an infusion that's just saline, things like that. And those can be part of clinical trials, but I'll tell you, by and large, clinical trials are not, they're typically using placebos to compare to the new medicine, but patients are often receiving some sort of standard of care already as part of the clinical trial. So for the vast majority of trials, you're never walking in just getting a placebo. You're typically getting something else as well. And I'll give an example of that in a second. Blinded, what does that mean? That means that a lot of times, especially in phase 3 clinical trials, your doctor doesn't actually know what therapy you're getting. And there's a purpose for that, and that is, we don't want to influence the results of the clinical trial. And so people are randomized in a kind of a flip of the coin matter, right? We have these computer algorithms that patients are randomized into 1 or 2 or 3 different arms, whatever it might be, and often the doctor is blinded. Not all studies are blinded. Phase 1 trials, phase 2 trials are typically not blinded. We know what the patients are getting. occasionally phase 3 trials are not blinded, but so that's part of something to talk about with your doctor, and something I always try to talk to with my patients about. So here's an example of a trial that we had in our network, and I think many of us were involved in, that just recently close to enrollment, but is still active. So this was a phase 3 clinical trial looking at a personalized cancer vaccine in addition to pembrolizumab for patients after surgery with people for melanoma. So these were patients with high-risk stage 2 melanoma, stage 3 melanoma, or stage 4 melanoma, in which they had no evidence of disease. They'd already been surgically resected, but had yet to receive any therapy. And so the standard of care right now would be to put them on some sort of adjuvant therapy, or at least offer that for this patient population. And that could be immunotherapy with drugs like pembrolizumab. Nivolumab would be another option as well. Potentially targeted therapies also would be an option in this population, but pembrolizumab is truly a standard of care in this population. And so what this study looked at is pembrolizumab by itself, which again, that's the standard of care, versus pembrolizumab with this personalized cancer vaccine. And so patients were randomized to be either in this arm or this arm. It was actually in a 2-to-1 fashion. So for every 3 patients, 2 patients were in this arm and 1 patient was just in the standard of care arm. Again, investigators like myself had no idea which arm the patients actually were in. So I was blinded to what treatment they're receiving. And so it's a randomized blinded study essentially, and we'll wait to see what the results of that are as we continue these patients on this trial and ultimately see what the outcomes are. So that's an example of kind of a blinded randomized study. How do we know if clinical trials work? Well, you saw a lot of great data from about targeted therapy and immunotherapy about improving outcomes, and that's ultimately how we know if they work. We have to follow patients through time, and it's a population of patients, and we're seeing our clinical trials seeming to benefit people. In a phase 3 clinical trial like this one, which Dr. Waite showed earlier, which was ipilimumab, nivolumab versus nivolumab versus ipilimumab in metastatic melanoma patients. Well, we followed these patients through time, and ultimately we saw that if you got that combination treatment, more patients were alive 5 to 10 years later than if you just got ipilimumab or in this case nivolumab by itself. And there's some nuances to that and whatnot, but that's how we ultimately know, do clinical trials work? As how do people respond? And then obviously we want to know, how are they safe? What are the ramifications of these treatments? What side effects do they get? Because unfortunately they do all come with side effects that we have to deal with. So metastatic patients, often we have tumors we can follow, right? We can see if the tumor shrinks, if there's a response. And so a lot of times we know it's working based on response rate, not just long-term outcomes. In patients who already had surgery and have no active disease left, we don't always know, we don't have a tumor to follow. And so those would be like the study I just presented earlier, where we were giving a new treatment after surgery. Well, in that case, we really have to follow patients over time to see if their cancer does come back. And so an example of this would be pembrolizumab given for stage 3 melanoma patients after surgery. At that time, there was no standard of care. It was just surgery, and we'd watch people. So pembrolizumab was compared to just a placebo. And again, placebo was the standard of care at that time. And what we saw as we followed people is that if you got pembrolizumab, you were less likely to have a recurrence of your melanoma than if you had placebo for that group of patients. So then we knew, okay, pembrolizumab is an effective treatment for this population. We use a lot of heavy statistical analysis, and we've got a lot of statisticians on these trials to help us kind of figure all these things out and know if it's a statistically significant result. Unfortunately, there's a lot of disparities in clinical trials, and that's something we as investigators continue to work on, and it's a big thing. And I think a big thing with Sarah Cannon Research Institute that we really try to focus on. Clinical trials are the foundation of drug development for cancer. It's critical that these trials represent the real world. They need to represent who are the patients out there, not just a small subset of patients. Unfortunately, there's fewer than 5% of patients with cancer that ever receive treatment on a clinical trial, and it's probably even much less than 5%, honestly. Historically, only 23% of oncology trials were conducted in the community, even though about 80 to 85% of patients actually get treated in that setting. So these trials were being conducted only at big cancer centers and not across the community. And that's where kind of the dream of a Sarah Cannon Research Institute is, hey, we need to get these trials out to the community, out across the country. And also because of that, patients who were older, over 70, even though they represent 42% of the cancer population, only represent about 24% of the trial population, and they represent less than 10% of NCI-sponsored trials. So, we're using therapies on these patients that are older that never were part of the clinical trial. So it's important that these patients get involved. It's important that we figure out how to get it to make it more ethnically diverse as well. Unfortunately, if we looked at who gets involved in clinical trials, and this was just kind of looking at patients who did report their race over a 10-year period in oncology, the vast majority are white or Asian, a much smaller population of Black, Hispanic, and Native American population. So we have a lot of work to do to continue to get trials to these underrepresented populations, because probably drugs can act different across different populations, and so we really need to know that information better. And we need to make clinical trials more accessible for people. If you look across the United States, this is a little map looking at geographic accessibility of cancer clinical trials by regions. And this is actually looking at metastatic breast cancer, not melanoma, but I think it's a similar concept. And in fact, even probably even in melanoma, where it's a less common tumor type, it's probably even more disparate, worse access. And so if you look, kind of in the Northeast, those patients, just because it's a more condensed area, they can probably find clinical trials within an hour of where they live. Along the coast, a smaller percentage can access clinical trials. As we get into the South, and of course these mountain regions, these are areas where they do not have very good access to clinical trials. The vast majority of the population live over an hour away from a clinical trial. So that's why we need to bring these trials to the people, I think. And so that's where traditionally we have these centralized models. You got a huge clinical trial or a huge cancer center run that has clinical trials there, and people have to get to that big, huge cancer center. And really, Sarah Cannon's probably more in this hybrid model where we have local participation, we have partnerships where we're bringing actual clinical trials into our community practices. And I think our goal would be, could we do even more of this shared care model where we could run research in any cancer center across the United States that we have access to, and use oversight with kind of principal investigators who are really involved in the clinical trial to help their local oncologists bring these new treatments to patients. So that's the dream. I think we're kind of more in the middle right now, where we have a lot of research centers set up across the United States, but they're still not in our very small offices. So we have to continue to move towards that so we can get more access for patients. That's the dream. Sarah Cannon Research Institute is a huge network of oncology cancer centers across the United States. Over 1,300 research physicians, over 250 locations in 24 states. And so we're trying to bring all these trials to all these little dots across the United States, basically. And if we do it successfully, we can reach 1 in 5 patients with cancer across the United States, which is remarkable. If you're thinking about a clinical trial, what questions to ask? Ask your doctor, what's the purpose of this study? Is it to see if to see the dose of this drug? Is it to see if this drug's going to beat out the standard of care? Ask those questions. How long will the study last? what are my other options? I always try with patients to just lay out, hey, here's the standard of care, here's this clinical trial and why I think it might be good for you. And it's not good for everybody. Not everybody is a perfect candidate for clinical trials or wants to be on a clinical trial, but I think it's important for us to talk through it with people. Ask, how did the tests in the study compare with those I would have outside of the trial? You know, am I going to have a lot of extra testing? Is it going to be a lot of extra driving to the center? What does that mean? You know, and again, that's where I think bringing these trials closer to patients is important so that it doesn't disrupt their life as much. And will I have to pay for any part of the trial? Typically, most clinical trials, anything experimental is paid for by the clinical trial. Sometimes the trial's even paying for even a standard of care drug. Other times it's paying for certainly extra studies, but there's a work with the insurance on what gets paid for by the trial, what gets paid for by insurance, and that's always something to discuss. Currently, all insurances are supposed to accept clinical trials as part of a treatment for cancer patients. And then how do I find clinical trials? It's confusing. There's clinical trials all across the US. And it's, you know, people often say, oh, I need to go here for a clinical trial. And the reality is there's clinical trials spread across everywhere. We may have a clinical trial at my office that somebody else doesn't, you know, across town or across the state, and vice versa. And so important to kind of look at different options and really talk that through with the oncologist, see what their thoughts are about it. Clinicaltrials.gov is kind of the big database of clinical trials. It can be a little cumbersome to look through, and probably need some interpretation with your oncologist or with some other people to really help guide you through that, what's on there, what's available. Organizations like AIM at Melanoma can help. Next generation sequencing reports that a lot of our patients should be getting also have information about potential clinical trials based on the patient's mutations. Artificial intelligence is trying to get there to help patients with clinical trial findings. So hopefully that continues to improve as well. Back to our patient, you know, this 2014, she had wildly metastatic melanoma. At the time, I was involved with the protocol for ipilimumab and nivolumab. I offered that to her as a clinical trial versus just getting ipilimumab by itself, I think at the time, and for a standard of care. She went on that clinical trial. She ended up being randomized to the dual therapy. And she went into complete remission, and she's still alive 10 years later today, which is awesome. And so that's why I do that's why I get involved with clinical trials, is to see these potential outcomes and how we can change people's lives. And now how we're using this treatment in clinic all the time to treat people and having these outcomes, but we still have a lot of work to do, right? We still have a lot of work to do. But we're getting better. You know, this is when I was young, I'd play Tecmo Bowl. It was pretty, you know, pixelated. Couldn't do a whole lot. My son plays Madden all the time now. They can do like a million different things, and he beats me all the time at it. But we're evolving, getting better, making things better all the time. So thank you to all of our patients and families. Thank you for attending this, and happy to answer any questions at our Q&A session.
Thank you so much, Dr. Iorio. Great talk. We're a couple minutes late on our Q&A, and I'm only going to be on here for a minute, and we'll get right to these questions that we have. So thanks to all of our presenters. I want to tell all of you who are out there listening a little bit about AIM, because it relates directly to what you've heard today. Quick story is how AIM started, and we had a family in California who had 3 daughters, and one daughter went to Brown University, worked a little bit, came home and was studying for her MCATs, her medical school tests. And she said to her mom, who, you know, I've got this pain in my chest. And they went to the doctor, and nobody really did much, but couldn't find much. And the pain sort of disappeared for a little bit. And then it came roaring back a few months later. And this time they got a scan. And it was what no one wants to hear, which was stage 4 melanoma. And Charlie is her name. Charlie died 9 months later. This was Thanksgiving 2003. You've seen some information today on how far we've come in treatments, and she lived about 9 months, which was what was typical then for a stage 4 patient for some. In 2004, in February, just a few months later, AIMIT Melanoma was officially formed. And that mother, Valerie Guild, the late Valerie Guild, who's passed away in 2020, formed AIMIT Melanoma, and we have been going for 20 years. It's our 20-year anniversary. And I think it's really important to tell that story because we were formed by a mother in conjunction with her daughter before she died to serve patients and healthcare providers in terms of education on melanoma, supporting people living with melanoma, and also finding the cure in our lifetime, which is our goal. And those are AIM's missions. That's part of our mission statement. So I'm going to share my screen to show you a little bit about AIM. And can you let me know if you can see it?
Not yet.
Okay.
Oh, we just saw it a second ago.
Got it. Okay. How about now?
No.
Well, that's great. Hold on. Now?
Not yet.
Oh, there it is. There we go.
Okay.
I
Something's
don't see
pretty
it.
slow. All right, I'm going to hold for a second and you tell me.
Oh, you had it up there for a second.
Wow, this is a little crazy. I'm going to hold right here and see if it comes up. You let me know. Otherwise, I'm going to just talk. Nothing?
No, I still can't see it.
Okay, so I'll just go back and just talk, and I'll put some of this information in later into the chat. But I think that the most important thing I want to tell you, besides our founding, is that AIM is very much a belief that you're best in your treatment and you're able to make better choices for your care if you're educated. And so this is where we come from, where we start from. Everything today that you have heard has pages on AIMIT Melanoma for your use. All the topics we discuss have pages, and just targeted therapy that Dr. Amatruda talked about, all FDA-approved drugs for melanoma, including new sections on TILs will be added today. Clinical trials section that just further discusses what Dr. Yorio has been talking about. We have a clinical trials matching service that's available. And AIM's website is the most comprehensive website available on melanoma. So we hope you'll visit. The most frequently visited pages are melanoma stages and their treatments and side effect management. Kind of interesting to us. So we always try to build those up. Other resources that we have for patients, we have a talk to a medical expert service, a woman named Melissa Wilson, who's an oncology PA in Pittsburgh, Pennsylvania at their melanoma clinic. She answers questions for people on a personal level. If you email or telephone in, there's a page on that. Please use her. Could I be eligible for clinical trial? What are the stages of melanoma? What are my treatment options? Those kinds of things that she can help you with that are not quite your physician level, but a little more personal than just seeing something on a web page. We also have a Melanoma Learning Center. We have From the Clinic to the Living Room webinars with Melissa, Melanoma 101 videos, and melanoma symposiums. That all of these symposiums are posted after they are live streamed like today, and they're available on that site. Last couple of things I want to tell you about. We have a great podcast with Dr. Raymond Liu of Kaiser Permanente, who discusses psychosocial issues like anxiety related to scans and interventional therapies and things like that. So I hope you'll go check out that kind of stuff. The final thing I want to tell you about is AIM's Peer Connect group. And melanoma patients have been looking for this for a long time. I know there are organizations out there that do all cancers where they try to connect you with a newly diagnosed person and a mentor who's fought through and survived melanoma. And it's hard because finding those people who all come to these pages and places need to be matched up with an appropriate person, like stage, and sometimes male, female, or just female to female, or what have you. People have their different requests. Our Peer Connect program has over 60 melanoma survivors and their Peer Connect partners, and we match you very carefully, a one-on-one support, a listening ear, and guidance in a safe, non-judgmental and confidential environment. And every one of the peer mentors has gone through some training. So these are the kinds of things that are available. I'm going to put our Director of Community Engagement's email in the chat for everyone to see if you have any questions on these types of resources, but that's a little bit about AIM at Melanoma. I'm going to hand it back over to Dr. McKean for her Q&A. So thank you very much.
All right, great. Thanks, Alicia, and thanks for that great presentation, Dr. Yorio. We've got a lot of questions about clinical trials in the chat, especially, and so hoping to get through a lot of, keep submitting questions. We'll kind of work through these. So first, actually, Dr. Amatrid, I'm going to start with you. We had a question. I have tested positive for the BRAF mutation. Can you help me understand how that impacts my melanoma treatment? That's certainly an area where we've learned a lot just in the last couple of years. So appreciate your thoughts as we think through and based on your talk about personalizing treatment.
That would mean that you have the opportunity to treat your melanoma with a pill, a BRAF inhibitor pill, and actually a combination of two pills. And the key question would be when in your treatment that might help you. We generally use immune therapy before BRAF inhibitor therapy for advanced melanoma because it seems like it both lasts longer and it may prime any later BRAF inhibitor therapy to work better. The situation where we might use a BRAF inhibitor therapy before immune therapy would be if you had a really rapidly growing melanoma, or if you had reasons that immune therapy might be ineffective or dangerous to you. Like if you'd had a kidney transplant, we can't give immune therapy then because we'll activate an immune attack against your transplanted kidney. Whereas the BRAF inhibitor therapy may work well. So I think it gives your care team a tool to treat the melanoma. The question is when to use that tool. It may be that you had this actually just detected early in your treatment course and there's no need to use it yet, but it may be an option for you in the future. And it can be a prognostic factor as to how well you're going to respond to different immune therapies. I don't know if that answers your question. If you have others, please feel free.
Feel free to put them in the chat, but I think that was great. Dr. Waite, we will move to you next. One question was, does TIL therapy work on all types of melanoma? And what do we know thus far about TIL and the different subtypes?
Yeah, no, that's a great question. We're still learning a lot about TIL and where it works best. The data that we showed today and the information that's led to the approval of TIL was largely in cutaneous melanoma, so those arising from the skin. One example would be, we just learned a little bit about this recently at one of our conferences, and for melanoma conferences is, a lot of clinical trials, and this is included, TIL included, when you have melanoma in the brain, you might be excluded from a trial until that area is treated effectively. And so for that reason, there weren't many patients treated with TIL on the clinical trials with melanoma in the brain. And so that's an area that we're still learning about. Does it work as well in the brain and in patients who have what we call brain metastases compared to those who are responding in areas outside of the brain? And so there's a lot of unanswered questions around who the treatment works best for. And we're just starting to sort of uncover that, and we'll learn a lot more in the coming years. A shorter answer to the question is we're still testing this therapy in mucosal melanoma, which is another source of melanoma, cytomelanoma. We're still testing this in uveal melanoma, which I think is an important area of research. There are a few very limited clinical trial opportunities in uveal melanoma for TIL, and so that is currently being evaluated to see how well it's working in other tumor types. So definitely more to come on that, but I don't think we're ready to say exactly how well this is working for everybody at this moment in time. But for cutaneous melanoma, we think it's a really good option.
Great, really helpful. Another question was about, it was from a patient that has an autoimmune condition. This example was rheumatoid arthritis. And the question was, my treatment has lowered my immune system. And also this patient was diagnosed with melanoma. So this is, a common patient scenario that we see in clinic. So I understand this was a risk of the treatment. So I can feel confused about how to proceed. Could you offer some advice? So we kind of touched on this a little bit when I said some of the risk factors. And certainly this a little bit gets back to Dr. Amatruda's point about BRAF mutations, but we're constantly trying to battle or help manage autoimmune conditions and any cancers in the setting of immune suppression. Happy to have any of my colleagues weigh in, but I think some of it just depends on stage of diagnosis. But I mean, certainly autoimmune conditions, we need to manage those, right? I mean, debilitating rheumatoid arthritis, that really impacts quality of life. And so sometimes we are able to offer treatments that don't stimulate the immune system. So I think there's kind of two ways to look at this. Preventing melanoma, unfortunately, if patients are on immune suppression to manage their autoimmune condition, that is kind of a risk that we all have to accept to try to manage those symptoms. But if a patient does develop melanoma, want to diagnose it as early as possible, hopefully it's surgically resectable. If not, then we look at other options such as, do you have a BRAF mutation? That's where clinical trials can be helpful because we have options for NRAS mutations or other non-immune therapy options. So certainly this is becoming kind of a bigger and bigger focus with research because it does affect a number of patients.
Yeah, let me add to that, Meredith. One of the issues we run into a lot is someone who has arthritis, say, and is getting a biologic agent against the arthritis, and then they get a melanoma. Can they continue their biologic agent? And there's really very little data on it because all the studies on the biologic agents like Orencia and other agents against arthritis excluded people who had melanoma. So the only information we have is large-scale tumor registry studies. And I just saw somebody yesterday and looked at it, and there's really no good evidence that continuing those agents increases the risk of melanoma recurrence. We still recommend close surveillance in somebody who is getting a biologic agent, say, against psoriasis or arthritis, and who has melanoma. But they may need that agent to treat their underlying immune disease. And at least right now, it doesn't appear that continuing that agent increases the risk of melanoma recurrence. I don't know what you all think about that, but I'm sure you run into it on a monthly basis. What do you think about continuing Orencia, say, in somebody who has a melanoma?
I guess I talked a little bit to this, but we do see this a lot. This is very common. So the individual asking the question, you're definitely not alone in this scenario. Those immunosuppressive medications are a risk factor for melanoma, newly developed, and probably a risk factor for these recurrent or higher risk melanomas. In our clinic, Dr. Armatruda, we occasionally treat patients who have these underlying autoimmune conditions with immunotherapy. I mean, not everybody has the BRAF mutation, not everybody has a clinical trial option, and in those cases, we continue. But most of the time, we talk with the other providers who are providing those immunosuppressive medications for treatment of rheumatoid arthritis or Crohn's or whatever it may be. to try to find the best possible immunosuppressive therapy, maybe the one that we think would be the least likely to interact with our immune therapy and our ability to fight the melanoma. And then we do treat a select number of patients with immunotherapy, and we continue those immunosuppressive medications in those patients to try to mitigate worsening of that underlying condition, rheumatologic condition or otherwise. And so that is something that's an approach that we've taken with some degrees of success. So the immunotherapy can work with those immunosuppressive medications that are ongoing. So that would be my comment.
Great. I think that was all hopefully really helpful. So here's a question I'll kind of throw out to the group, and then we'll kind of dive into some of the clinical trial questions. But this is a common question I think we get in clinic. Do the side effects mean that the immune therapy is working or not working? If working, should I tough out the side effects for as long as possible? So Dr. Iorio, I don't know if you want to start with that one and give your thoughts, because I think that is it's certainly a question that comes up in clinic a lot.
Well, I think it depends on the therapy. I think about it differently with targeted therapies versus immunotherapy as far as side effects goes. I'm not so sure that increase in side effects with targeted therapy necessarily means that that's working better. And certainly happy to hear others' thoughts on that. However, immunotherapy, I do think there's certainly, and data's been out there that there's some evidence that people who have really severe immune toxicities with immunotherapy might have a better immune response against their melanoma. But the caveat there, I would say, is we've probably all seen patients who have very little toxicities from their immunotherapy and still respond to treatment. And we've all seen people who have had really intense responses, immune side effects to their immunotherapy and have not had the response that we thought they would have. So by and large, I'd say with immunotherapy, probably more side effects probably means a little greater efficacy, but it's not true for every single person. It's just, if you looked at the big number of percentages. So I think that's an important thing to discuss with your doctor, when's the right time to maybe stop treatment based on the side effects. And I think we also know with immunotherapy, stopping treatment doesn't necessarily mean you're going to stop responding to that treatment long term. You might still see a longer term response, and it might be the right thing to stop that treatment if you're having a large amount of side effects.
Go ahead, Dr. Wright.
Yeah, I'll piggyback just a little. Everything Dr. Iorio said, 100% correct. We're still learning a lot about side effects, toxicities, how they interact with responses, and it's an area of ongoing study. So, and it's certainly an interest of mine. I would just comment that for those who are on treatment, have a side effect that is significantly challenging in some way, I would not be fearful of stopping your treatment in order to manage those side effects. There's some early information going back a few years, especially with ipilimumab, that those who are treated with steroids for an immune-mediated side effect due to necessity and have to come off treatment do maybe even a little bit better than those who aren't treated with steroids and don't have as significant of a side effect. And so there is some of that out there that we're still sorting out. And certainly there can be some risks with treating the side effects and tamping down the immune system, but you shouldn't be fearful of stopping your treatment if your provider, physician, whomever recommends that to you due to a side effect, because these responses can be ongoing, as Dr. Iorio mentioned, even when you stop the treatment and have to treat the side effect. That would be my additional comment.
My patient I mentioned earlier that was on that clinical trial who had this robust response to ipilimumab and nivolumab actually had one of the worst immune toxicities I've ever seen and has not had any treatment, had very little treatment, had about 3 months of treatment and never since, and still is 10 years in remission. So that's an example of somebody who ended up needing a treatment of their immune-mediated side effects, but ultimately still responds even 10 years later. So
yeah, fantastic. I completely agree. I think certainly pushing through is not necessarily the answer, and at the very least discussing any of your symptoms with your doctor. It's a little different than immune therapy, is a little different than something like targeted therapy. So I think those are some great points. Here's a good clinical trials question. It says, are clinical trials primarily for people who are not responding to their existing treatments? Love that question because I think that comes up a lot. So we like to think that clinical trials should always be the first option. Like, what's the latest, greatest thing to treating your cancer versus waiting till last resort? But I appreciate if any of you want to dive into that and just how you think about clinical trials and opportunities for your patients.
Yeah, no, I think you're exactly right. I think I'm always thinking about clinical trials anytime I need to make a new treatment decision. And it may not always be right for people, and it may not, be the right time for people. But it's something at least to discuss. Now, we have a lot of better frontline treatments, right? Like, things like combination metastatic treatment or some of the treatments we now have for adjuvant after people have had surgery. So for a clinical trial to be right, it's really got to be a good potential clinical trial where you're not giving up the potential standard of care. I would not put somebody on a phase 1 clinical trial who's never seen any treatment before, unless that clinical trial is really going to add something to the standard of care. And it might be looking at a new combination that might have some good potential. But I wouldn't necessarily forgo some great standard of care option for something that might be much less. However, if it makes sense for that person and it might add to that person's treatment, then I think it's worthwhile. And that could be at any point in the juncture and not just when they've exhausted all standard of care options.
Yeah, I think great point, Dr. Yorio. And, right now for melanoma, there's several good clinical trials in the adjuvant setting for stage 3, right? What more can we add to just our single agent Keytruda or Opdivo to, a patient that with stage 3 disease has a 40% risk of recurrence. We decrease that with single agent anti-PD-1 by 40%. Well, that takes us from 40% to like 25%, which is good, but can we do better? Right. And so there's a couple trials ongoing in that space, trying to look at combination therapy. So I think that's one example of where even early stage disease, hey, is it worthwhile to maybe take a look at what clinical trial opportunities are out there, and could it be beneficial for you or, patients in the future? And so I think it's worthwhile just to ask your doctor, take a look and look at resources like AIM at Melanoma, just to educate yourself on all your different options. Go ahead, Dr. Amatruda.
Yeah, and I want to just follow up on what Dr. Yorio said. I completely agree that it would not be the best interest of somebody to forego a potentially effective therapy for a purely experimental phase 1 treatment. But you have to think of the fact that during the treatment course of multiple treatments for a cancer, you are changing and your immune system is changing. It's possible that you may have, by the time you are ready for a clinical trial, your immune system may have been exhausted. That's, for example, one of the reasons why Dr. Wade has talked about moving the TIL therapy into first-line treatment. It may be the immune system is more flexible and robust at that point, and you can get a stronger immune response to the TIL therapy rather than after 2 or 3 other lines of immune treatment. Also, it's one of the arguments for doing genetic testing or genomic testing early in the course of care, because it may be that we can identify a targetable mutation while somebody is still able to take experimental therapy for it, rather than at a late phase in treatment when somebody's body has been really ravaged by previous treatment.
Great, that's fantastic. Well, I know we're right at 12:30. Unfortunately, we have several other great questions I'd love to get to, but also trying to make sure that we respect everyone's time. So wanted to thank my fellow panelists for their presentations today. We hope you all found it helpful, and I'd like to thank the AIM at Melanoma Foundation for this opportunity to be with all of you today. So I'll turn it back over to Alicia.
And my thanks to all of you, and for all of you listening out there. This will be posted on our website in a number of weeks, and you can re-look at the information, re-listen to the information. And panelists, thank you for this Saturday talk. It's really important. Patients love listening to you, so thank you very much. Appreciate it.